Welcome to this new course entitled Safe Patient Transfer, Movement, and Immobilization Techniques. At the conclusion of this module, you will be able to describe the basic principles of body mechanics, proper lifting, and transfer techniques, identify standard patient positions and the range of immobilization techniques, explain the importance of quality communication with patients, describe the reduction of patient radiation exposure by using proper immobilization methods, and finally, apply immobilization techniques in routine situations, trauma, and pediatric situations. We will now focus on immobilization principles. Any movement during the image will negatively affect the image. Immobilizers are used to control movement of a body part. They can be used to remind a patient to stay in a particular position or to prevent a patient from falling from an examination table or a gurney. Immobilizers can also be used to prevent self-injury by impact with diagnostic imaging equipment. The laws governing restraints and immobilizers are different. In radiology, we use this terminology to avoid conflicts with different laws. Restraints are used to assist in the maintenance of normal body functions or to prevent the patient from removing a tube or dressing that may be life-sustaining. Restraints need to be approved by a physician before they can be applied and must be removed and the patient reassessed every 2 hours. There are two basic types of restraints. Physical restraints holds the part in place using physical means. Chemical restraints use drugs to incapacitate the patient and prevent movement. Three common physical body restraints are the limb holders, ankle or wrist immobilizers, and vest immobilizers. Limb holders are applied to the extremities. Ankle or wrist holders are applied to the ankle and the wrist respectively, and vest immobilizers are applied to the torso. The basic principle of immobilization is to prevent movement. Motion distortion is one of the most significant contributing factors leading to unacceptable image quality. Immobilizers will also reduce positioning inaccuracies, which also contribute to suboptimal image quality. Motion distortion can result from involuntary and voluntary patient movements. Immobilization prevents voluntary movements. Communication should always be used before any immobilization. Communication is also critical to achieve effective immobilization. The patient will be more cooperative if they understand the reason behind the immobilization. As mentioned earlier, immobilization can control voluntary motion. However, involuntary motion can only be controlled by using short exposure times. Use immobilization aids when possible. Before applying any immobilization, the technologist should explain the procedure to the patient and the reason behind the immobilization. Immobilization should be carefully applied to allow the patient as much mobility as possible. Immobilization devices touching the skin should be padded to avoid injury to the skin. If a knot is used, it should not become tighter with movement. Immobilization should not be tied to a moving part, such as a bed frame. Even if the patient is immobilized, the patient must never be left unattended. There are numerous types of immobilization devices. Positioning sponges are radiolucent. Sheets, Velcro straps, or tapes can wrap around and immobilize a part. Head clamps will hold the head in place for sinuses, facial, and skull imaging. Sandbags are radio-opaque supports. There are also commercial devices. The ideal patient immobilization device should be radiolucency, flexible, durable, easy to duplicate, safe and reliable, and should not produce image artifacts. Such immobilization devices are very specific. The cervical collar is used only for the neck when there is a case of suspected fracture. Similarly, the spine board is used for spinal injuries. Splints and stockinette are used to immobilize the limbs. Positioning sponges are commonly used to allow for increased accuracy by supporting the patient or anatomic area of interest. Make sure sponges are radiolucent and free of artifacts. Sandbags are extremely helpful in reducing voluntary motion. However, because sandbags are radio-opaque, they cannot be placed over the area of interest. Tape can be used to immobilize the extremities. However, the sticky part of the tape should not be in direct contact with the skin. A cloth sponge can be placed between the tape and the skin to prevent skin damage. Tape is not very strong and is best used on patients who are cooperative but are unable to remain motionless during exposure. Pediatric immobilization should be only used as a last resort and is effective when used with communication techniques and a development of a rapport with the patient. The technologist should use kindness, honesty, patience, and attempt all communication methods with children on their own level. Never use threats or force, and always work with parents when following department policies and procedures. The mummy wrap is an effective, simple, inexpensive, and reliable method of immobilizing children that are 12 months or under. It is also called the mummification technique. The sequence starts with placing the child in the center of a triangular folded sheet. Keep the shoulders just above the top fold of the sheet. Next, take the left corner of the sheet over the left arm and under the body so that most of the sheet extends beyond the right side of the body. The child should not lie on their left arm. Tuck the part of the sheet extending beyond the right side of the body. Again, make sure the child is not lying on their arm. Bring the remaining sheet over the body and tuck the sheet securely under the left side of the body. Regardless of how securely the child is immobilized, the child should never be left alone, even for the amount of time needed to make a radiographic exposure. This means a parent or guardian should stand next to the child during the exposure. Commercial immobilization devices include upright devices such as the Pigistat infant immobilizer and the PD poser, or recumbent devices such as immobilization board. This board is a contour fitting support with a pad, mold, or sponge with attached Velcro straps for securing the patient. The Pigistat infant immobilizer and the PD poser can be used on children up to 3 years old. It can be used for upright chest and abdomen radiography. The advantages of the Pigistat infant immobilizer include the following. Once secured, the child can be rotated 360 degrees for a PA, lateral, or oblique projections of the chest. It has a built-in adjustable lead shield for gonad protection and right and left markers. Because it is translucent plastic, the child can be observed during the exposures. The child is held securely and safely, which greatly reduces the need for repeats due to motion. It reduces the necessity of having someone hold the patient, and it includes a respiration phase indicator. The disadvantages of the Pigistat infant immobilizer include the following. The plexiglass that encircles the patient can become damaged. The damaged cracks sometimes produce linear artifacts on the image that may mimic a pneumothorax. The device may not allow a child to take a deep breath. This device is not suitable for the seriously ill or post-operative patients. The patient must be conscious, and the patient must be able to sit up. An example of an immobilizing board is the octostop. The child can be imaged securely using this device. Velcro straps keep the child in place, and the child can then be rotated 360 degrees in 8 different positions. The material is radiolucent and durable. This device is limited to pediatric patients up to 1 year old. The most common spinal trauma traction device is the cervical collar. All projections can be produced with a cervical collar in place. Patients are placed in a cervical collar and often on a spinal backboard. The cross-table lateral AP and AP open mouth projections may be performed to evaluate the cervical spine during a cervical trauma examination. These projections are obtained with the collar in place. The collar should not be removed until the images are cleared by a radiologist and confirmed that it is safe to move the patient without the collar. The cervical collar is used for spinal trauma immobilization. Patients may come on a backboard to protect the spine from further injury. The backboard is radiolucent and can be used to lift and transport the patient. Like the cervical collar, the backboard should not be removed until the images are cleared by a radiologist. The radiologist will also confirm that it is safe to move the patient without the board. Stockinette is stretchable cotton fabric in the shape of a sleeve. They can be pulled over a fractured extremity before a plaster cast is applied. Stockinette is effective in immobilizing the limbs. It is pulled over the upper or lower extremities of a child and secured with tape. Splints are used to support both ends of a fractured bone. The devices can be inflatable or air split. The inflation cuffs are anti-shock devices used to stabilize the patient for transport to the urgent care center or hospital.
Thanks for watching. To purchase the full course and earn your CE credits, click on the link in the description or head on over to our website at www.medical-professionals.com. And while you're there, check out our All Access Pass, where you can get unlimited CE credits for your state and ARRT renewal for just $49.99. We also offer a host of free resources to make it easier than ever for radiologic technologists like you to achieve excellence. Check out our free Radiology CE webinars, clinical reference guides, and free CE courses on our website today. Be more than just certified. Choose medical professionals.